Note the P wave in lead 2. It is 3 millimeters wide and 2.5 millimeters tall. So it is biatrial hypertrophy. Now see the P wave in lead V1. The P wave has a broad negative component. In lead V1, P wave is biphasic. The first positive component is right atrial and second negative component is left atrial. So left atrial hypertrophy can also be diagnosed from a broad negative P wave in lead V1. This picture suggests ventricular tachycardia or supraventricular tachycardia with bundle branch block. RR interval is 9 millimeters, so the heart rate is 165 per minute. To differentiate the two conditions, see leads V1 and V6. A deep S wave in V1 and a broad R wave without Q wave in V6 tells us that this is left bundle branch block. So this is supraventricular tachycardia with left bundle branch block. Here is a premature beat with compensatory pause. The QRS structure is normal, so it is supraventricular. So study the P wave. It is upright but slightly different from the sinus P waves. So this is an atrial premature beat. Study the P waves in this ECG. Tall peaked P waves in 2, 3 and AVF. This is P pulmonale of right atrial hypertrophy. In this ECG, study the ST segments. In 2, 3 and AVF, there is ST elevation of 5 millimeters. The T waves are upright. Leads 1 and AVL show reciprocal ST depression. So this is a fresh inferior wall infarct. Now let us see the chest leads. There is reciprocal ST depression in V2, V3, V4 and V5. So this is an extensive infarct. This ECG shows a normal beat followed by a run of ventricular premature beats. It heralds ventricular tachycardia. Study the chest leads. The QRS complexes are 3 millimeters wide. There is RS-R' pattern in V1 and V2 indicating right bundle branch block. A broad S wave in V5 and V6 supports our diagnosis. So this is right bundle branch block. In the limb leads, there is left axis deviation. Normally, right bundle branch block should have right axis deviation or a normal axis. Left axis deviation suggests associated left anterior hemiblock. This is lead 3. Deep Q wave and raised ST segment indicate inferior wall infarct. Now study the P wave and PR interval. The PR interval is 11 millimeters or 0.44 seconds. So there is first degree heart block also. Diagnosis is fresh inferior wall infarct with first degree heart block. This is a premature beat with compensatory pause in lead V1. The QRS complex is broad with tall slurred R wave of right bundle branch block pattern. Note the P waves. The P wave is altered in the premature beat. So this is an atrial premature beat in a patient with right bundle branch block. In this ECG, study the limb leads. The QRS complexes are broad. Concentrate on lead 2. The P wave is very close to the QRS complex. There is no PR segment and a delta wave is seen. This is WPW syndrome. With this, we come to the end of this cassette. I expect that after studying this cassette, you will be able to diagnose common conditions with ease. But be aware that there is much more to read in ECGs than what we have seen till now. There are many more fine points and differentiations, but that is for a cardiologist to read. It is beyond the scope of this cassette, which at its best is an introduction to basic electrocardiography. If the basics are understood and common ECGs interpreted with ease, then the cassette has served its function. Thank you.